Welcome to Prism Rounds. If you are joining us for the first time, or if you're a long-time listener, this is the place where we break down one study at a time. We are stripping away the noise to get to the signal. We take the source material, the raw data, the manuscripts, the appendices, the editorials, and we turn it into a conversation that actually makes sense for your practice.
And today we have a truly significant piece of research to discuss. We are looking at the SONIA trial coming out of Kenya. This is a study that tackles one of the most common and deadly conditions clinicians face, community-acquired pneumonia. But it tackles it in a way that, well, I think it really forces us to rethink our assumptions.
Before we jump in, we have to do the mandatory housekeeping. Just a reminder to everyone listening that this deep dive is for educational purposes only. We are here to explore the literature, analyze the data, and stimulate your critical thinking. Nothing we say here should be taken as specific medical advice for the patient right in front of you.
Exactly. We are reviewing the evidence to help you interpret it, but the application always depends on your specific clinical context.
So, today's menu. We are looking at the SONIA trial, which was published in the New England Journal of Medicine, and we're also going to layer in the insights from the accompanying editorial. It's titled, Old Therapy, New Context.
Which is such a perfect title for this discussion. I mean, it just nails it. The old therapy is adjunctive glucocorticoids steroids. We have been fighting about steroids in pneumonia for decades. It feels like every few years the pendulum swings one way or the other. The new context is where this trial takes place, and that is what makes it so groundbreaking. This is about treating pneumonia in low-resource settings.
Let's unpack that immediately, segment one. Why does this matter? Because I think for a lot of people, when they hear pneumonia trial, they assume it's another study out of a massive academic medical center in Europe or North America.
That's true.
A place with unlimited resources.
Right. And that is the disparity we need to address right at the top. Pneumonia is ubiquitous. It is everywhere. But the resources to treat it are not distributed evenly across the globe.
Yeah.
Not even close.
The sources mention a pretty staggering statistic regarding the burden of disease. I had to read it twice.
They do. In sub-Saharan Africa, the case fatality rate for community-acquired pneumonia, or CAP, is 3 to 5 times higher than it is in high-income settings. Just let that sink in for a moment.
3 to 5 times.
It's an enormous difference. You are 3 to 5 times more likely to die from pneumonia there than you are in, say, a wealthy nation in the West.
That is a massive discrepancy. And yet, as the editorial points out, most of the research guiding our guidelines, the IDSA guidelines, the European Respiratory Society guidelines, it all comes from those high-income settings.
Precisely, and that's the fundamental problem. We are essentially exporting guidelines built in environments of abundance to environments of scarcity. And they don't always fit. That is the gap the SONIA trial is trying to fill.
Okay, so tell us about the setting. Where exactly did this happen?
This study was conducted in 18 public hospitals in Kenya. These are part of a clinical information network, which is a really impressive setup for collaborative research.
Right. Now, when we say hospitals, it is important to understand the level of care we are talking about. Paint the picture for us. What does a level 1 referral hospital in Kenya look like in terms of critical care capacity? If I'm a doctor walking the halls there, what am I seeing?
You're seeing a very constrained environment. The study authors are very clear about this. These are described as level 1 referral hospitals, but you have to be careful with that term. It doesn't mean the same thing everywhere. The key detail is that these hospitals often have limited, or in some cases, virtually non-existent ICU availability.
So patients who, in a Western setting, would absolutely be in an ICU, or at least a high-dependency unit. Where are they here?
They're on the general medical wards. That's the reality. The ward is handling a much higher level of acuity than we might be used to.
So this is the trial designed specifically for that real-world, lower-resource hospital setting.
Yeah.
It's not trying to replicate an ICU in Boston. It's trying to see what works in a general ward in Kenya.
Exactly. And that context, it drives the entire clinical question. The question isn't just, do steroids work in a vacuum? The question is, can a low-cost, widely available intervention like a short course of steroids reduce mortality in a setting where mortality is tragically high?
And where you don't have the backup plan. If a patient fails on the ward in a high-resource setting, you intubate them, you start vasopressors, you dialyze them, you have a whole cascade of rescue therapies. In this setting, the ward is often the ceiling of care.
That is the crucial point. When the ward is the ceiling, you need interventions that prevent the crash, because you can't always rescue the crash. The focus shifts from rescue to prevention.
Okay, so let's look at the intervention itself. What exactly did they do? How did they structure this?
It was a very clean design. They took adults aged 18 and older who were hospitalized with a clinical diagnosis of community-acquired pneumonia. They randomized them to receive either standard care alone, which we will get into, or standard care plus a 10-day course of low-dose glucocorticoids.
And the primary goal, what was the finish line they were looking at?
Hard outcomes, 30-day mortality. They weren't looking for subtle changes in biomarkers or length of stay. They wanted to know if this intervention saves lives, period.
I love that. No surrogate endpoints here. Just, are the patients alive or dead at 30 days? It's unambiguous.
It connects directly to the theme of that editorial we mentioned. We are desperate for effective, low-cost interventions in these settings. If you have a setting where, maybe 1 in 4 people might die from this common infection, and you don't have a fleet of ventilators or advanced vasopressors, finding a cheap drug that cuts mortality is, well, it's the holy grail.
Let's move into segment 2 and break down the study design, because the word pragmatic appears in the title. And usually when I see pragmatic, it means messy but real.
Messy but real is a fair characterization, but I would probably say designed for reality. It was a pragmatic, open-label, randomized controlled trial. Each of those words is important.
Let's stick on that pragmatic label for a second. Specifically regarding the diagnosis, you mentioned earlier that these patients had a clinical diagnosis. What does that mean in practice?
It means they were enrolled based on what a clinician could see, hear, and measure at the bedside. In a typical pneumonia trial in a high-resource setting, you would expect really strict inclusion criteria. You'd need a chest X-ray with a demonstrable infiltrate, maybe even a CT scan, and probably a formal severity score like the PSI or CRB-65 calculated for everyone.
But not here.
Not here. And that is by design. Because in many of these 18 hospitals, chest imaging is not consistently available 24/7. If they made a chest X-ray a requirement for enrollment, they would have excluded the reality of the patient population. They would have filtered out the very people they needed to study.
So you'd get a study full of patients who were lucky enough to get an X-ray, which isn't representative of everyone who comes through the door.
Exactly. So the inclusion criteria were based on clinical signs: cough, fever, dyspnea, chest pain, crackles on auscultation, the kind of stuff a doctor can figure out with their hands, their ears, and a thermometer.
That is a crucial detail. It reflects the local constraints. If the doctor hears crackles and the patient is hot and coughing, that's pneumonia, and they are in the trial.
Yes. Formal severity scores were also not required for enrollment. This creates a bit of a challenge later when we try to compare this cohort to, say, a cohort in the U.S., but it ensures the results apply to the patients actually being seen in these Kenyan hospitals. It prioritizes external validity for that specific region over perfect internal homogeneity.
Okay, let's talk about the drugs. You said glucocorticoids, plural. Which one? What was the dose?
This is another fascinating pragmatic element. So the intervention was standard care, which involved antibiotics, according to WHO guidelines, typically a beta-lactam plus a macrolide.
Standard stuff.
Right. Plus 10 days of oral steroids. But the specific steroid depended on what was locally available on the hospital pharmacy shelf.
Oh, that's interesting. So it wasn't just everyone gets prednisone.
No, they actually had a second level of randomization within the treatment arm. Depending on what was in stock at that particular hospital on that particular day, patients could get dexamethasone at 6 milligrams, prednisolone at 50 milligrams, or methylprednisolone at 30 milligrams.
Whoa.
They also started with hydrocortisone and prednisone in the mix.
That is wild. It's like a basket of steroids.
Yeah.
How did they justify lumping them all together?
They were aiming for bioequivalence. The doses were chosen to have roughly the same anti-inflammatory potency. But there is a logistical note here that I found really interesting in the paper. They actually had to discontinue the hydrocortisone and prednisone arms early on.
Why is that? Did they not work? Was there a safety signal?
Nothing to do with efficacy or safety. It was pill burden. To get the equivalent anti-inflammatory dose with the locally available formulations of hydrocortisone or prednisone, patients had to take a whole handful of pills. And in a patient who is breathless and sick and maybe nauseous, that's just not practical.
Right. If you are gasping for air, the last thing you want to do is try and swallow 6 pills. It's a choking hazard.
Exactly. So they streamlined it. They dropped those 2 and focused on the others: dexamethasone, prednisolone, methylprednisolone, which required fewer tablets to get the job done.
That is the definition of pragmatic research. You find out halfway through your study that the pill count is too high, and you adjust. It's solving a real-world problem.
It really is. And it highlights that in global health, the formulation can matter just as much as the molecule. You can have the right drug, but if the delivery mechanism, in this case, the number of pills, is wrong, The intervention fails.
I want to pause here for a teach the fellow moment, because this is something that trips people up. We mentioned this was an open-label trial. That means the doctors and the patients knew who was getting the steroids. And usually we frown on that. We want double-blind, placebo-controlled. That's the gold standard.
It is the gold standard, ideally, yes. But in this setting, think about it. Manufacturing a placebo for 3 or initially 5 different types of steroids would be prohibitively expensive and logistically impossible. You'd need matching placebo pills for every single variation, so they had to go open label out of necessity.
So how do we know the doctors didn't cheat? How do we know they didn't look at a patient and say, ooh, this guy looks really sick, I really want him to get the steroids, and then somehow manipulate the system to make that happen?
This is where the concept of allocation concealment comes in. And it is a distinct concept from blinding. They are not the same thing.
Okay, let's unpack this. What is allocation concealment? How does it work?
Allocation concealment protects the moment of randomization. It is the process that ensures that the person enrolling the patient cannot predict or know which group the next patient will be assigned to before that assignment actually happens.
So they can't game the system.
Exactly. They can't peek. In SONIA, they used a very classic, low-tech but effective method. They used centrally prepared, opaque, sealed envelopes. The sites received these batches of envelopes, all numbered sequentially. The protocol was strict. You confirm a patient is eligible, you obtain their consent, you officially enroll them in the study, and only then do you open the next envelope in the sequence to reveal their assignment.
I see. So even though I know what the patient is getting after I open the envelope because it's open label, I cannot steer a specific patient into a specific group before I open it. I'm committed before I know the assignment.
Precisely. This reduces selection bias at the point of entry. Without allocation concealment in an open-label trial, you might see a doctor unconsciously or consciously skipping an envelope or delaying enrollment for a sicker patient because they have a hunch about what the next assignment is. Or maybe they hold back a healthier patient to try and get them into the control group to make the treatment look better. The sealed, opaque envelope is a firewall. It's a low-tech but highly effective way to maintain the integrity of the randomization process.
That is a great explanation.
Yeah.
So even if you can't have blinding, you absolutely must have allocation concealment.
You must. It's non-negotiable for a high-quality trial. In a study of over 2,000 patients, that integrity is everything. If the randomization is broken, the whole trial is broken.
Okay, moving on to segment 3, the patient population. We've talked about the hospitals, but who are the people lying in the beds? Who are we actually treating here?
This is so important because we need to look at the demographics. They look quite different from what we typically see in Western pneumonia literature. The total number of patients, the N, was 2,180. The median age was 53 years old.
53. That is young. I mean, really young for a pneumonia trial.
It is very young. If you look at pneumonia cohorts in Europe or the US, the median age is often in the 70s or even 80s. This reflects the different population demographics of the region, but it also speaks to the burden of disease on the working age population. These are people in the prime of their lives being struck down by this.
And the gender balance.
Pretty even. 46% women, so good representation there.
Now, you mentioned earlier that they didn't use formal severity scores like PSI or APOTANTI. Does that mean these patients weren't that sick? Is this just run-of-the-mill pneumonia?
Not at all. And this is a critical point that the editorial makes. Just because we didn't measure the severity with a formal score doesn't mean the severity wasn't there. There were very strong severity signals in the raw clinical data, in the vital signs.
Give us the data. What do they look like on admission?
Okay, so 37% of these patients had an oxygen saturation and a SpO2 of less than 90% at admission.
Wow. Okay. More than 1 in 3. That is profound hypoxemia. These are patients who need significant respiratory support right out of the gate.
They're very hypoxic. And then you look at hemodynamics. About 8% had a systolic blood pressure less than 90 millimilli Hg.
So they were hypotensive, in shock or pre-shock.
Yes. So if you put that together, nearly 40% are hypoxic, nearly 10% are in shock. These are sick patients.
They are very sick. And it's worth repeating, they are on general wards.
In many places, an SpO2 of 85% or a systolic of 88 lands you in an ICU, or at the very least a step-down unit. Here, that is the ward population. The threshold for what constitutes ward care is much, much higher in terms of acuity.
We also have to talk about the disease ecology of sub-Saharan Africa. This isn't just pneumonia in a vacuum. There are comorbidities here that really change the clinical picture.
Absolutely. The big one, of course, is HIV. In this trial, about 16% of the participants had a confirmed HIV infection.
That's a significant portion, 1 in 6.
It is. But what is even more telling, and speaks to the reality of care, is that a large portion of the patients had an unknown HIV status. They simply didn't know. The test hadn't been done or the results weren't back.
Which again points to the resource constraints. You are treating a potentially life-threatening pneumonia in a patient where you might not even know their underlying immune status.
Exactly. I mean, just imagine the clinical uncertainty that creates for the physician at the bedside. You have a patient with a lung consolidation. Is it bacterial pneumonia? Is it pneumocystis pneumonia, PJP? Is it TB? And you don't know if they're HIV positive or what their CD4 count is. It changes the differential diagnosis immensely.
It's like flying half blind.
Yeah.
And on top of the infectious comorbidities.
We also saw a significant burden of non-communicable diseases. Hypertension was present in about 14% and diabetes in about 5 to 6%. So you have this complex mix of infectious comorbidities like HIV and non-communicable diseases like diabetes and hypertension all layered on top of this acute pneumonia.
It really emphasizes that the researchers didn't try to filter out the complexity. They didn't say, oh, let's exclude anyone with HIV because it makes the data messy. They said, this is who walks through our door, so this is who we're studying.
And that is the absolute strength of the study. It has massive external validity for the region. If they had excluded HIV patients, the results would be useless for a clinician in Kenya because that is who they treat every single day.
Okay, let's get to the main event. Segment 4, the primary outcome. The headline, the big question, did the steroids work?
The short answer is yes.
Let's have the numbers. What was
Wow.
the mortality difference?
All right. The primary outcome was 30 all-cause mortality. In the glucocorticoid group, the group that got the steroids, the mortality rate was 22.6%.
22.6%, okay. And the control group, the ones who just got standard care.
In the standard care group, the mortality rate was 26.0%.
Okay, so 22.6%, VSS 26.0%. And the stats, what was the hazard ratio?
The hazard ratio was 0.84 with a 95% confidence interval of 0.73 to 0.97. The p-value was 0.02. So it is a statistically significant reduction in mortality.
All right, I want to play devil's advocate here, or maybe just the skeptical clinician listening to this. 22.6 versus 26.0, that is a difference of what, 3.4 percentage points? That doesn't sound like a landslide victory. It sounds like it cut mortality in half. It sounds modest.
And that's a completely fair first impression. And it brings us to our second Teach the Fellow moment of the episode. We need to distinguish between relative effects and absolute effects and why baseline risk is the most important variable in the room.
Okay, lay it on us. Relative versus absolute. Break it down.
The hazard ratio of 0.84 represents the relative effect. It's saying that at any given time point, the risk, the hazard of dying in the steroid group is roughly 84% of the risk in the control group. You can think of that as a roughly 16% relative reduction in the hazard of death.
Which sounds decent, but maybe not earth-shattering.
It is decent, but the key is that you can have a great relative reduction that means almost nothing in the real world if the baseline risk is tiny. If your risk of dying from something is 1 in a million, and I give you a drug that reduces it by 50%, a huge relative reduction, your new risk is 1 in 2 million. I haven't really changed your life much. The absolute benefit is minuscule.
But here, the baseline risk is not 1 in a million.
Exactly. Look at the control arm. The mortality was 26%. 1 in 4 patients who got standard care died. That is a massively high baseline risk. When you apply that modest-sounding relative reduction of 16% to a huge baseline risk of 26%, you get a very meaningful absolute risk reduction.
Which is that 3.4 percentage points.
Right. And what does 3.4 percentage points mean in the clinic? It means that for every 100 patients you treat with this steroid regimen, you save roughly 3 to 4 lives that would have otherwise been lost.
So the number needed to treat, the NNT, is somewhere around 30.
Roughly, yes. You'd need to treat about 30 patients to prevent 1 death. In the world of critical care and acute medicine, an NNT of 30 for a mortality endpoint is a home run. It's a huge win. Think about aspirin for acute heart attacks. Think about thrombolytics for stroke. They are in that ballpark. An NNT of 30 means if you have a ward of 30 pneumonia patients, using this cheap, available drug will likely result in one of them walking home who otherwise would have gone to the morgue.
That really puts it in perspective. 3.4% sounds small on paper, but 1 life saved per 30 patients treated is huge impact at a population level.
It's massive. especially when you consider the sheer volume of pneumonia cases these hospitals see. Thousands and thousands of admissions. Those 3.4% add up to hundreds and hundreds of lives saved very quickly.
So the baseline risk drives what the benefit feels like at the bedside. That's the take-home.
Correct. And this is why the context is so important and why we have to be careful extrapolating. If you did this same trial in a U.S. community hospital where the baseline mortality for ward pneumonia is maybe 3% or 4%, that same 16% relative reduction would yield a tiny absolute difference. You might need to treat hundreds, maybe thousands of patients to save one life, but in Kenya, where the mortality is 26%, the impact is magnified enormously.
That is such a crucial concept. The context determines the value of the intervention. It's not just about the drug, it's about the environment the drug is entering.
But, and there is always a but in medicine, we have to talk about the cost. And I don't mean the price of the pills, I mean the physiological cost. This brings us to segment 5, safety and implementation.
Right. Steroids are not candy, they have side effects. What did we see in the adverse events data? Was there a big price to pay for this benefit?
Overall, the rates of serious adverse events were actually pretty similar between the two groups. However, there was one predictable signal that stood out, just as you'd expect.
Yes, sugar.
Sugar. Hyperglycemia. It occurred in 16.6% of the patients in the steroid group.
So about 1 in 6 patients are spiking their blood sugar on these drugs.
Yes. And while in a high-resource ICU, we treat hyperglycemia with an insulin drip and hourly finger sticks, and it's annoying but manageable. In a resource-limited ward with fewer nurses and maybe less lab support, hyperglycemia is a genuine threat.
The editorial really hammered this point home, didn't it? They called it the resource trap.
They did. The authors of the editorial, Dr. Quezera and Dr. Dunser, make a brilliant point. They say the drug is cheap, the steroid pills cost pennies, but the system required to safely monitor the side effects is not cheap.
You need glucometers. You need an endless supply of test strips. You need nurses who have the time to check the sugar every few hours. You need insulin available if it goes high. It's an entire infrastructure.
Exactly. It's a whole cascade of care. If you just flood a hospital system with steroids, but you don't have the capacity to monitor blood glucose, you might be trading death from pneumonia for death from diabetic ketoacidosis or hyperosmolar hyperglycemic state.
And they mentioned that the prevalence of diabetes is rising rapidly in Africa.
It is the double burden of disease. You have the infectious diseases and the non-communicable diseases hitting at the same time. So this isn't a theoretical risk. Introducing steroids as a standard of care requires a concurrent strengthening of the laboratory and nursing capacity to handle that predictable hyperglycemia. You cannot just prescribe the drug and walk away.
There was another adverse event that caught my eye, and it speaks to that diagnostic uncertainty we talked about earlier, tuberculosis.
Yes, this was a really interesting and important finding. Pulmonary TB was reported as an adverse event in both groups. It accounted for around 16% to 20% of the adverse events reported.
Wait, explain that to me. How is TB an adverse event of a pneumonia trial?
It's likely that these patients were enrolled with a clinical diagnosis of bacterial pneumonia, but it turned out, upon further investigation, that they actually had active TB. Or perhaps they had both. But remember, the diagnosis was clinical. TB can look a lot like bacterial pneumonia cough, fever, crackles, shortness of breath.
And giving steroids to someone with active, untreated TB
is generally considered a bad idea. It can suppress the specific immune response that is keeping the tuberculosis in check and potentially lead to disseminated disease. The fact that TB showed up as an adverse event highlights the incredible difficulty of differentiating CAP from TB without advanced imaging like chest CTs or rapid molecular tests like Genexpert, which may not be available.
So the implementation challenge is twofold. 1, can you manage the sugar? 2, are you sure this isn't TB you're about to treat with immunosuppressants?
Correct. It adds a layer of complexity. You can't just treat this as a fire and forget intervention. It requires clinical vigilance. It requires a system that can reevaluate the diagnosis if the patient isn't getting better, and a system that can catch the sugar if it spikes.
Let's move to segment 6, subgroups and limitations. Because usually when we see a big positive trial like this, the next question is always, who specifically should I treat? Did they find a sweet spot in the data?
Everyone wants the subgroup analysis to give them the answer key. Only treat the hypoxic patients, or don't treat the HIV patients, or it only works in people over 60.
Did we get that answer? Was there a particular group that drove the benefit?
Not really, and this is a very important point about trial interpretation. They reported the subgroups. They looked at age, sex, HIV status, O2 saturation. But, and this is the key, the study was not powered to detect differences between subgroups.
Meaning, there just weren't enough patients in each little bucket to be statistically sure that a difference you see isn't just due to the play of chance.
Exactly. The confidence intervals for the effect in each subgroup were wide, and they all overlapped. So we can't say with certainty that Group A benefited and Group B didn't. The best estimate of the effect for every subgroup is still the overall effect for the whole trial.
What about the hypoxemia factor? You mentioned almost 40% were hypoxic on admission. That feels like a group with a lot of inflammation.
It does, and the editorial suggests this is a key area for future research. We know from other trials, like the COVID-19 trials, that steroids often work best in the sickest patients, those with high inflammatory states, often marked by hypoxemia. In the SONIA trial, the interaction test for hypoxemia wasn't statistically significant, so we can't make a definitive claim. But logically, combining steroids to reduce inflammation with oxygen therapy to treat the consequence of that inflammation, that seems like the physiological sweet spot.
It makes mechanistic sense. If you have enough inflammation to cause your lungs to fail and become hypoxic, you probably have enough inflammation to warrant steroids.
Correct. It's a plausible hypothesis. But we can't hang our hat on it based on this data alone. For now, we have to treat the main result as the primary finding. There appears to be a broad benefit in the overall population they studied.
Okay, let's talk about the biggest limitation, which is essentially a giant warning label on the study: external validity. Can I, a doctor working in a well-resourced community hospital in Ohio or Manchester or Sydney, take this study and apply it to my patients on the general ward?
The editorial gives a very strong all-caps warning on this: do not extrapolate.
And let's be clear, why not? The biology of pneumonia is the same, isn't it? An inflamed lung is an inflamed lung.
The basic biology might be similar, but the context and the risk are radically different. As we've discussed, the baseline mortality in the SONIA control group was 26%. 1 in 4 people died. In a non-ICU setting in a high-income country, mortality for community-acquired pneumonia is much, much lower. It might be 3 to 5%.
So if I give steroids to my 3% mortality population,
The absolute benefit is going to be tiny, maybe even non-existent, because the event rate is too low to modify in a meaningful way. But you will still see all the side effects: the hyperglycemia, the delirium, the fluid retention, the secondary infections. You risk causing harm for a benefit that might not even be there in your population.
the risk-benefit ratio completely flips on its head.
Exactly. In the context of SONIA in Kenya, the very high risk of death justifies taking on the risks of steroid side effects. In a low-risk setting, it probably does not.
There's also the issue of the definition of severe CAP being tricky here, right?
Right. In a U.S. trial, when we say severe CAP-PA, we mean you're in the ICU, you're intubated, or you're on vasopressors. In SONIA, physiologically severe patients, people who are hypoxic and hypotensive, were being managed on a general ward. So the definitions don't map perfectly. The patients in SONIA were physiologically severe, but structurally located on a ward. That's a unique phenotype.
So the message is, don't just cut and paste this protocol into a system it wasn't designed for.
Precisely. This is evidence for low-resource settings. Generated by researchers working in low-resource settings, it stands on its own merit for that specific context, and that's a powerful thing.
Let's bring it all together in segment 7, practical takeaways. We have a listener, maybe a clinician working in a resource-limited setting, or maybe a trainee who is trying to understand global health. What are the Monday morning instructions? What do you do with this information?
I think we can synthesize this into 3 key pillars for practice.
Okay, pillar number 1.
Efficacy. The SONIA trial provides high-quality, randomized evidence that adjunctive low-dose steroids reduce 30-day mortality in hospitalized adults with community-acquired pneumonia in these specific high-risk, low-resource African settings. If you are working in that setting, this is a practice-changing result. This is the green light to consider this therapy.
Pillar number 2, the how.
Safety guardrails. Implementation isn't fire and forget. This is not a simple intervention. It requires systems for glucose monitoring. If you can't check the sugar, you need to be very, very careful. And you need to maintain a high index of suspicion for the diagnostic uncertainty we talked about, especially tuberculosis, so it's a package deal. The drug comes with a non-negotiable need for monitoring and clinical vigilance.
And the third pillar, the where.
Context is king. This is the big one. External validity matters more than almost anything here. Different settings with different baseline risks and different patient populations and different resources may not see the same benefit. Do not apply this blindly to low-risk pneumonia populations and high-resource settings. The data just isn't there.
I want to zoom out for a second and ask how this fits into the bigger picture of pneumonia research. We've had other big steroid trials recently, Cape Cod, REMAP-CAP. Where does SONIA sit on the bookshelf next to them?
That's a great question. It sits very comfortably alongside them, but it's in a different section of the library. Cape Cod and REMAP-CAP were landmark trials that showed us that in severe SACP, mostly in ICUs in wealthy countries, steroids save lives. SONIA takes that concept and asks a different but related question. What about the patients who are physiologically severe but are stuck on a ward because there is no ICU for them to go to?
And the answer seems to be consistent directionally.
It is directionally consistent, yes.
Yeah.
It supports the broader biological hypothesis that when the systemic inflammation from pneumonia is high enough to cause organ dysfunction like hypoxemia, then steroids which dampen that fire are likely to improve survival. SONIA beautifully validates the old therapy of steroids in the new context of African general wards.
It's almost like the puzzle pieces are coming together. Different severities, different locations, different resources, but a consistent signal that for the sicker patients, this probably works.
I think that's a fair summary. And, it empowers clinicians in these regions. As the editorial noted, for a long time, they have had to rely on guidelines written in Europe or America that may not apply to their patients. Now they have locally generated context-relevant data. That is a huge milestone for global health and critical care research.
Absolutely. It's a form of evidence sovereignty, the ability to generate your own answers to your own questions.
Well put. That's exactly what it is.
So, to wrap up the trial itself, we have a pragmatic RCT showing a modest but clinically meaningful mortality reduction. We have a clear warning about the need for monitoring, for the guardrails, and we have a powerful reminder that geography and resources define clinical reality.
That sums it up perfectly. The drug, the system, and the setting. You need to consider all three.
Here's a final thought for you to mull over as you finish your commute or your workout. We talked a lot about how the unknown HIV status and the lack of diagnostic tools like X-rays and TB tests define this patient population. Imagine if we poured resources not just into the therapies, like cheap steroids, but into the diagnostics in these settings. How much more effective could this steroid intervention be if we could perfectly and rapidly identify the true bacterial pneumonia from the TB or the PJP, or if we could risk stratify patients better? The drug is cheap. The knowledge to use it perfectly, that's what's expensive, and maybe that's where the next big breakthrough lies.
That is the next frontier, isn't it? Precision medicine isn't just for fancy cancer centers in the rich world. It's about getting the right cheap drug to the right patient in a hospital in Kenya, too. That's the real challenge.
If you found this deep dive helpful, please share it with a colleague. Send the link to your team. Let's get the conversation started. And subscribe so you don't miss next week's study.
Stay curious and keep questioning the context.
Thanks for listening. We'll see you next time on Prism Rounds.